I bet this scenario sounds very familiar to you. Imagine you're on a course, you're having a great time. I personally love courses. I think you all know that. You're on your 5th coffee and everything's going great. And suddenly your pocket starts vibrating. You got a call from the practice or a text message from your receptionist saying that, Mrs. Smith, the root canal that you saw yesterday, she's in absolute agony. And you curse because you think, wow, that was a completely straightforward root canal procedure. The patient was asymptomatic before you even started. Why is this happening for me? Look, post-op pain after endodontics is an absolute bitch. It's one of the most annoying things ever. It actually puts me off doing root canal treatment because of the one in how many of a chance that post-op pain incident's going to happen. And I'm going to discuss with Sanj Bhanderi, who did such a brilliant job in that GF017, where we talk about how to extirpate properly and efficiently. So if you haven't listened to that one, oh my goodness, you are in for a treat. Go back and listen to that one. But in this episode, we're focusing more on post-op pain. Like, how do you manage that kind of scenario? What do you say to the patient? How can you prevent this from even happening in the first place? It's funny, I've actually had 4 root canals on my own self. Now, before you think, oh, Jazz, that's disgusting, you got caries, etc. No, it was actually trauma from orthodontics. Can you believe it? Orthodontics devitalized my lower 4 incisors, and I've had all sorts of issues and root canals and fractures, etc., and now have a resin bondage zirconia bridge, hence why I'm so passionate about those bridges. Anyway, I experienced post-op pain myself. It was a nasty thing, there was lots of inflammation, and so I've been there, and I totally empathize with my patients. Before we join the main episode, I just wanted to say yesterday I released new tickets to Finlay Sutton's masterclass. So Finlay Sutton, he travels all around the world. He was in USA last week, he goes to Scandinavia a lot, he teaches us everywhere. If you think removable prosthetics, you think Finlay Sutton. He's just a phenomenal educator and the best in the space when it comes to removable pros. Now, he came on for episode 56, how to make chrome dentures easier, so check that one out if you haven't already either. But he's doing a live one-day partial dentures masterclass on Saturday the 14th of January, that's 2023. So if you'd like to join us, go to protrusive.co.uk/Finlay. That's Finlay. It's limited to just 12 delegates only, and it's a very rare chance to see him down south. Usually you have to go to his practice up north, or you have to go abroad. So he very rarely comes south, and so if you'd like to join us, including the dinner the night before, it'd be great to have you. So once again, the link is protrusive.co.uk/Finlay, and there's also a payment plan to split your payment into 3 if you need that. Anyway, let's join the main episode. I recently treated a gentleman. I talked about this gentleman on the podcast. Necrotic canine, very strange, severe bruxis. I suspect some airway issues. We're investigating that at the moment. Like, to the extent that 50% of his canine is just shot. The canine was dark in color. My dentist, who I inherited his list, has been he's had a couple of bouts of antibiotic in the past for this tooth, and he just felt he's too young. He's in late 20s to have a root canal on a canine. He just couldn't figure out why it went necrotic, but it did. I tested everything. It was necrotic. I went inside this canine, it was necrotic, it was infected. So I confirmed that, and then I did a root filling. And my goodness, and I'd followed all the right protocols, hypochlorite, gutta perca, everything was done to a high standard. Radiograph looked good, there was no extrusion of the GP or anything. But my goodness, was this chap in so much pain, and he ended up in A&E. They did some bloods on him. They didn't find any sepsis, but they found high inflammatory markers in his bloods, actually, interesting enough. So that was my one really bad experience about 4 months ago. Otherwise, I don't tend to get significant post-op pain, but I've been with dentists at conferences. Sanj, we've been at a conference on a course, and the dentist nips out at 11 a.m. because there was a root canal he did yesterday. The patient's now in agony after finishing the root canal. So what do we know in terms of you're probably there lecturing and speaking, your phone's probably vibrating saying, Mrs. Smith from yesterday. What is behind that? What causes that? Okay, even in your expert hands, is it just bad luck, or do we know what causes it, and then therefore what steps can we take to minimize its occurrence?
I think it's quite multifactorial, and some of it is unpredictable. There are certain conditions that seem to predispose patients having what's called a flare-up. A flare-up, by definition, the endodontic definition of a flare-up is this is in between treatment or after treatment. If treatment's been performed and the patient gets acute pain that requires treatment, they have to attend. So that's the definition of a flare-up. There are a few things, I suppose you can break down to patient factors. So we're talking anxiety levels. We're talking about there are some certain genetic factors. Some patients are more predisposed to pain, period. And definitely if there's
yes, absolutely. We know that from TMD, chronic back pain, the study of pain itself is, we know that people are much more susceptible to pain than others, yeah.
So on those particular patients, and also talk about the symptomology, it's patient management. If you pre-warn them It doesn't mean that they're not going to be out of pain, but they can handle it. It's when they're not expecting the pain, that's when the problems start, and it just increases anxiety level. So it's better patient management, and those patients you get a kind of alarm bells. These patients are a bit tricky, or if you've seen patients before previous treatment, they've always the tooth's taken ages to settle down, or even root. So that's the first thing. In terms of the actual tooth itself, it's the inflammatory stage of the tooth. So pre-existing lesions, if there's an apical lesion, radiographic lesion, those teeth are more susceptible for post-operative or intraoperative pain. Okay, so for me, before the endodontic treatments, we always preload our patients with anti-inflammatories, not just emergencies, but routine root canals, and especially retreatments, and especially if there's a lesion already on the tooth. We know that they're more predisposed to flare up, so just preload them anyway with anti-inflammatories or painkillers. And then during the procedure, you've got to do utmost to follow what we now call, as everyone knows, a crown down protocol. You do not want, in a necrotic case, the whole majority of the canal space is going to be infected. Often it's actually not. The apical tissues are actually not infected. Just because there's an apical lesion, that apical lesion, unless there's an abscess or suppuration, it's not infected. It's just the inflammatory process. And we need to remember that, because the last thing you want to do is push bugs into the apical area, or even worse, through. And it can happen easily. I'm sure one of the main reason you get a flare up is because we've inadvertently pushed biofilm through. It happens sometimes. So we just got to do our utmost to go down, crown down. And so as you do that, the reason for that approach is you're flushing out bacteria progressively with minimal risk of pushing it ahead of the instruments. This is one reason, going back to the emergency treatment, you don't fish around the root canals, because if the canal happens to be necrotic in that multi-rooted tooth, two of them are inflamed, the other one, you shove bacteria further down, you're going to inoculate areas which weren't actually infected. So that's another reason not to fish around the root canals, going back to the emergency situation. So in this situation where it's necrotic in that canine, you do your utmost just to work your way down. Now, some endodontists, traditional endodontists, will say you should be dressing all those cases. You don't do those in one visit. That's another area, just to decrease the bacterial load because of the calcium hydroxide. That's the evidence suggests it probably doesn't matter. You can do those in one visit. But the evidence for one visit.
Sanj, that reminds me actually that I think we were coming to the same point here. I believe there was a systematic review comparing one visit to two visit, and they found that they're both equally successful, but you might get more flare-ups in one visit. Is that what you're going to come to?
You get more post-operative pain. Hopefully not flare-ups, but the patient, they'll get more post-operative pain. That is
post-op pain. Yeah, that's what I mean. Sorry.
Yeah. Flare-ups is a different situation. There's also the patient factors in terms of their immune response. Everyone's different. We're dealing with immune responses which we can't control, apart from maybe anti-inflammatories. And I think the body, this happens in teeth that have got lesions, apical lesions. There's an inflammatory process that's been going on for a long, long time. The patient's been asymptomatic. The body's kind of, in simple terms, the way I explain it to the patients, the body's got used to having an infection in the tooth, and it's reacting slowly. Sometimes when we go in, it may not be that we've pushed debris through, we've changed the balance, whether it's pressure, whether it's something else has changed, and we just disrupt that. And it's a short-term reaction they're going to get. And again, I warn them, when there's a big, radiolucent area, you think these are the sort of cases they're going to kick off. It doesn't matter how well you do the endo, it's going to kick off. I pre-warn those patients. There's a chance this is going to kick off, okay? So it's patient management, and if it does kick off, then you can deal with that. But it's the fact that they know about it. They often won't bother contacting you. They'll say, I just took anti-inflammatories. You see them on the second visit, visit and think, well, it was fine, it settled down. So there are those situations you are...
Now Sanj, you speak to your patients afterwards, you warn them big time, you document it, and you still have that, you're teaching at a conference and your phone is buzzing, and you speak to Ms. Smith from yesterday who had that root filling finally finished, and then she's experiencing post-op pain. Now, the temptation, oh my goodness, the temptation is so much for her to come in and then to do something, and usually that something is, here's some moxilin, 500 milligrams or something like that, and that temptation is there, and I don't cave in, and that time he ended up in hospital, and the hospital doctors gave him antibiotics. He got better eventually, okay, but do I honestly think it was due to antibiotics? I think he would have got better anyway due to inflammation, is what, because they found no microbials in his body. They found a high inflammatory marker in this particular instance. How should we manage it? Is it okay just to say, look, don't worry, you'll be fine, give it time? Or is there ever a situation where antibiotics is justified?
I think in antibiotic...
In post-op pain?
Yeah, I mean, with the current guidelines in antibiotic microbial management, whether it's NICE or whether it's the endodontic, European, whatever, I think if you start getting systemic involvement... Now, it's again, you've got to be practical about this. there's an abscess, like I say, it could be fluctuant swelling, it could be cellulitis kind of symptoms. You know, this is not just localized and apical periodontitis kicking off. There's definitely soft tissue involvement. Then I think in the short term, even a short course of an antibiotic with anti-inflammatories dosed up, I think that's justified. If there's no obvious signs of an abscess, cellulitis, spreading infection, then it's just high dose painkillers. With or without codeine, if it's affecting the sleep, something like dihydrocodeine, GF017, something like that, just to get them through that pain, and hopefully it'll calm down. It is a tricky one though, because it's nice. There's a theory about
it's so tricky
when you're in practice and you've got the patient there, but you shouldn't really throw them antibiotics. You've got to have good justification for doing it. If there's a fluctuant swelling, incise it, freeze the area, incise it. If you haven't finished the endo, open the tooth up. In terms of leaving an open drainage, 24 to 48 hours, you can leave an open drainage just to relieve the pressure, but you've got to go back and get them back in. Okay, get them back in. Try and get some drainage. It's back to surgical management.
Now, in those scenarios, let's say we are in between visits, and let's say we've done our crown down protocol where we've got the canals as clean as we can, and we aim to obturate at the next visit, and it's in between that initial cleaning of the canals and actually obturating, the patient comes out with a flare-up in between those two visits. So you're not quite ready to obturate because you haven't got that diary time to obturate, but the patient's now sat there. If we were to go back into that tooth, let's remove our cavit or calcinol and go back in this instance, would you recommend taking the file all the way to the apex, or how would you manage that scenario?
If you've got the working length, then just go back in and kind of semi-reprep. Just get the calcium hydroxide out. It may be the fact that you haven't got the dressing material all the way to length. One thing actually worth mentioning, between appointments, always dress the tooth. Never leave it dry and empty. Never. Always put something in it, and calcium hydroxide is the thing to do. The difficult thing is getting the calcium hydroxide in volume to length. If you only squirt at the top end of the canal, it's not going to have any effect apically. You don't get the benefit of the properties, So open it up. The fact you open the system up, you relieve pressure, because it's usually apical pressure that's causing the pain. Whether you get suppuration, it doesn't really matter. I think you're just opening up the pressure. Some endodontists would say you got your working length, go a little bit patent. You're not going to do any harm. If anything, you might release or relieve any micro abscesses down there, and then wash out again with hypochlorite, redress and close up, and then your chemotherapeutics, your anti-inflammatories and things like that. Painkillers and things like that after that.
Well, this was a tough question compared to the emergency one, because it's a scenario we hate. As dentists and as endodontists as well, we hate this scenario of finishing an endo and then they have that initial acute inflammatory reaction, what we believe, and they just got to wait it out, and eventually it will get better. We know that, okay? But it's that patient at the end of the chair who's suffering, and we feel bad for it. I felt devastated, Sanj, when it happened to my patient, but I really do, in my hand of hearts, believe it wasn't my fault. Now, I do think perhaps I shouldn't have been so heavy-handed, maybe. I was using rotary instruments for a canine, and maybe some extrusion of the debris, dentinal debris could have happened, exacerbating that inflammation. I put my hand up there, that could have been it. But in those scenarios, I think the lesson is, let's not be too hard on ourselves. Let's promote anti-inflammatories. Let's warn them that this could happen, and then they can then self-manage and not expect it, but if it happens, they're not like completely in shock. And then only if justified with swellings and cellulitis, consider antibiotics. And then I guess during the treatment, the crown down approach. Now, just for any students listening, the last thing I want to ask you is just describe, make a tangible, an example of a crown down approach for a molar root canal, for example.
Okay, I'm glad you asked this question, because I think this is quite important from a technical point of view, but also from an antibacterial preventing a flare-up. Because I think the majority of flare-ups are due to stuff being pushed through the end, debris, infected material. I think that's the most common reason why. So the protocol is, you found the orifices. This is when you've got time. Okay, so going back to the emergency dressing. So the golden rule is, just to recap the emergency dressing, unless you've got time to go down to full working length and confirm it, don't go into root canal space. Okay, that said, so your second appointment, you've got the time. You booked into the root canal, you find the orifices, and the only thing you're going to do now is you're going to confirm the orifice in what we call, the endodontist called scouting. You can use a 10 to 15 size file just to confirm that there is a patent canals there. And when I mean patents, I mean patent coronal, not the patency we're talking about at the end. Once your canal is there, then you go on to, most people using rotary systems or reciprocating. I've got a slight reservation about reciprocating systems. They're not as efficient as removing debris. So if you prefer a reciprocating system, wave one, reciproc, or whichever one, just be careful. You wash out more frequently. You clean the files more frequently, because they get clogged up. because of the nature of the way the instruments work. With rotary, you're going to use the system in its sequence. Okay. My rule is, and this goes against a lot of what the manufacturers suggest. Once you found the orifice, they often say go down, get your working length, and then you go through the system. That goes against the principles of disinfection, because you could shove coronal bacteria. Majority in necrotic teeth, majority of bacteria is at the top end. It's not actually the apex, which I mentioned. So the last thing you want to do is shove biofilm further down. So you've got to get rid of that. So the coronal preparation in the mid-third is really important before you worry about working length. I do the majority of the preparation up to the estimated working length. I knock off a quarter of that. I'll do that blindly without an apex locator reading. How do I know the estimated length? I've got a decent pre-op radiograph. And I knock off a quarter, I'm safe. I know I'm going to be well short. And I'll go through the whole preparation sequence to that point, so that all I've then got to do once I've prepared the canal to 3/4 is confirm the working length. I know everything's clear, because apically there's going to be virtually no biofilm or bacteria, and there's less chance of me pushing any rubbish through. And also, because I've opened the system up, your working length determination is more predictable. It doesn't change, because working length changes from the start of the preparation to the end. It gets shorter. So another reason, if you do your working length at the beginning, by the time you've finished and flared at your prep, you're probably going through the apex. If you keep that working length, it's to do with geometry in the curved canal. So I do the coronal 3/4 prep without worrying about the working length, and then I'll confirm the working length, and all it's doing is finishing off. And you've disinfected everything up to that point with less risk of pushing debris through. So I think that's really important, which goes slightly against what a lot of manufacturers and some endodontic teachers teach. And I've stuck by that.
Biologically, it makes so much sense to me, I think, because otherwise, in practice, it's like a race to the apex, which it shouldn't be. It should be clearing, just like you said, the coronal portions first to allow you to get better access to the apex. So it's very much, I listen to your lectures, Sanj. I listen to your lectures. Sanj, listen, thank you so much for giving up this afternoon to speak to me. We've made 2 episodes out of this, basically, so-called group functions, where we answer one key pressing theme. So we talked about extirpations. So if you haven't listened to that one, go back and listen to that one. It was brilliant. And now we just covered post-op pain and flare-ups. At the end, you covered really beautifully just a good description of a crown-down approach for young dentists and students to really consider. And even just the oldies to have been, oh, you know what, I should probably go back to doing that rather than going straight to the apex. So, Sanj, please tell us about, I know you teach at the moment with institutions, but what kind of private courses do you do? Where do you do them? Is it all in Manchester? Tell us more.
Yeah, so at the moment we do a good friend of mine, Amar Al-Rani, was my postgrad student. He's now established in London. So we both run courses, 2 and 4 day courses in London and Manchester for convenience, because I'm in Manchester and he comes up and I go down to London, so it's quite good fun. So we do 4-day courses, and we're going to be doing a longer program next year. We've got plans for doing a longer, something like a diploma course next year, so I'm looking forward to that. And also do a microsurgical course. We did our second one a few weeks ago, and it's a human cadaveric course. It's the only endodontic cadaveric course that I'm aware of in Europe. And that's been going really well in Coventry. So West Midlands, we've got another one coming up in March. I think it's nearly fully booked. So that's quite good. And microsurgery is another little area of mine, pet subject of mine. So, and a lot of people limited with interest in endo or specialists don't come across good surgical training. So that's something I think is really needs to be shared. And
any website you can recommend for us to check out these courses?
No, most of the things once we've got days, we issue them on social media and the usual dental forums and Insta and things like that. I'm a bit old fashioned like that. I'm getting into all that sort of thing. We put posts out. We haven't got a website as such yet. So that's an ongoing thing. So I should be getting a new website for the practice, and all the courses will be there. But essentially, just keep a lookout on social media.
When you do, give it to me, so I'll put it on the YouTube and on the podcast in the summary, because people want to know. People enjoy the content. They think, I identify with this educator. I like the way he thinks. I like the way he or she speaks, and so therefore I want to be able to connect people who want knowledge to the person who can help them upskill. So please do send me those links when you can. And it's no surprise that you work with Amar Al-Rani. He came on as a guest actually in the podcast some time ago, and we talked about, is single point obturation adequate? Is it okay for dentists to do. And you know what? He gave such a lovely, just like you did, a very real world, very diplomatic, very sympathetic to the plight of the GDP. So hats off to both of you. I love clinicians like this who don't sit in their ivory towers. It has to be this way. I hate dogmatic approaches. And so Sanj and Amo, if you're listening to this, thank you so much, guys. It's obviously great to have you as the endobods on this podcast. Thank you so much, Sanj.
Thank you, Jazz.
Well, there we have it, guys. The joys of post-op pain now covered by Dr. Sanj Bhanderi. Sanj, thanks so much for creating these 2 amazing episodes. And thank you, Protrusive, for listening all the way to the end. Now, you come this far, why not answer a few questions to claim CPD for listening to this? Like, think of all the different memberships that you have, all the online memberships, and you think, when was the last time you logged in? When was the last time you used it? Well, you just listened to a podcast episode and you've learned something, hopefully. So why don't you actually test your knowledge, get the CPD certificate, and actually get some reflections as well. So if you're on the app, you can do that now. As a premium member, you get CPD certificates and a whole load of exclusive content. So if you haven't already, do check it out. Otherwise, I'll catch you same time, same place. Bye for now.